So you can start the session.
Okay. So we'll start. So good evening to all of you. This is, I think, the 98th session edition of this challenging case series. I will, as usual, I will start with my short case first. Is my screen visible to you all?
Yes, sir.
Okay. Okay, Bindu, we'll start. Now, this is a story of a 3-year-old boy. His parents noticed that the child was walking unsteady since the time child started walking, and with history of recurrent falls while walking. He was born of full-term normal delivery. There was delay in motor milestones, but the social and language milestones were normal. Child started sitting with the support by 9 months, started walking by 2 years, and used to have recurrent falls since then. The unsteadiness remains same, but the falling episodes has improved a little bit. The father was said to have similar imbalance while walking since childhood, and he started walking independently only by 8 years. Since then, he is walking normally and was walking in gulp presently. So this is the child. You couldn't make out any abnormality. There was no nystagmus. The kind of normal. Scanning type was.
Full name പറഞ്ഞൂടെ? Full name എന്തുവാ?
ഇതിന്റെ പേര് പറഞ്ഞേ. വാച്ച്. ഇതോ? മിടുക്കനാണല്ലോ. ഇതോ? ഇതിന്റെ മോന്റെ ഇൻഫോർമേഷൻ മൂക്കിന്റെ പുറത്ത് തൊടണം. പൊക്കി തൊട്ടെ. കുന്നോട് തൊട്ടെ. മൂക്കി തൊട്ടെ.
അതിന് മൂക്കി തൊട്ടെ. നമുക്ക് മൂക്ക് എന്ത് ചെയ്യും? മൂക്ക് തൊട്ടാണ്.
Both apples is important. Power was relatively normal. Okay, medical. ഈ കാല് കൊണ്ട് ഇങ്ങനെ തൊട്ടെ. It's important to lower limb as well. medical. നീ കാല്.
നീ ലെഫ്റ്റ് കൊണ്ട്.
ഇവിടെ തൊട്ടെ പൊക്കി തൊട്ടെ. The reflex was normal in the upper and lower. Language check I couldn't get. Maybe because may not be really absent. Ejects are slightly brisk. So pendulum eject is there. Angle jack couldn't elicit. I don't know if this plan is really upgoing, but it is not consistently upgoing. When the gait of the child, it was unsteady with broad base.
Thank you.
So what do you think the probable etiology in this child? His father was affected by the same illness, which improved. It's now working in gulp. The child also had the similar ataxia from the time child started walking. His speech was also affected. So we can see some familial ataxia. What do you think most likely cause would have been? Is it a spinocerebellar ataxia or a congenital cerebellar ataxia syndrome? So this is the MRI of the patient. It's normal. There's not much of atrophy seen in the cerebellum. Cerebroplastin was normal. Alpha fetoprotein was normal. Lipid profile was also normal, except for triglycerides slightly elevated. So examine his father. This is father. He's about 35 years. He has casebook nystagmus.
ഇവിടെ നോക്കി ഇവിടെ ഇവിടെ മുകളിൽ
Ocular movements were normal.
പല്ലിയണിച്ച്
Rest of the kindness were all normal. And speech is also normal.
മുറുക്ക് 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 മതി മതി കണ്ണ് തുറന്ന് വാ തുറന്ന് ആന്ന് പറഞ്ഞ് ആ ആ നാക്ക് നീട്ട് തിരുവനന്തപുരം എന്ന് പറഞ്ഞ് ഉറക്കെ ഞാൻ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നത്.
Speech of the structure to a scanning speech.
ഇത് പിടിച്ചോ
Power was normal in upper and lower. He had mild incoordination, very mild incoordination.
അങ്ങനെ ചെയ്തു.
Almost normal on the right side, mild invert on the left side, slightly.
അങ്ങനെയല്ല നേരെ
The only power was normal.
ബലപ്പിച്ച് ഇതിലും പിടിച്ച് ബലത്തെ പിടിക്കണം. മതി വിട്ടോ അത് മുകളിലോട്ട് അടിച്ചോണ്ടിരിക്കുക അതിനെ പിടിച്ചോണ്ട് മതി ചെയ്തേ
It's got heel shape coordination is present in both movements.
കറക്റ്റായിട്ട് ഈ കാര്യം ഉണ്ടോ ഈ ചാടാട് മുട്ടിക്ക് ഇനി ഇവിടെ എടുത്ത് വെക്കുക കറക്റ്റായിട്ട് ശരി മതി.
Plus the upper limbs are normal. The lower limbs are also normally elicited, slightly brisk nature.
ഇതിനും കൊടുക്കാതെ ഇതിനും കൊടുക്കാതെ
Angle jacks are normally elicited. Radar was flexor.
അറിയുന്നുണ്ട് ഒരു വൈബ്രേഷൻ ഇപ്പോഴുണ്ടല്ലോ
Vibration is normal in upper limb.
ഇപ്പോഴേ
It's normal in the lower limb.
ഇതിന് താഴെയോ മുകളിലോ എന്ന് പറയണം. ഇപ്പൊ എങ്ങനെയാ
No impairment in the joint sense.
ഇപ്പോഴേ ഇപ്പോഴേ ശരി.
This is the gait of the patient. He couldn't stand even with eyes open. He was unsteady.
കാല് മാറ്റരുത്.
He needs to fall to either direction. And
നേരെ നേരെ കണ്ണടക്കണ്ട. ഞാൻ അടവിൽ നിന്നാ
it walks with a broad pace and tandem walking was given.
ഒരു കാര്യം യൂണിവേഴ്സിറ്റി പാക്കേജ് ഞാൻ ഇപ്പോൾ നോക്കാം.
His history is also having the same problems in childhood. That is the story goes. And he improved from the imbalance and is persisting like that till the age of 30 to 40 years. His son has had the incoordination from early childhood. Now, this is the finding in his father. So, what do you like to do? What do you like to, what is your thinking about these two patients? Any thoughts? What could be the possibility?
Early onset Ataxic SL autosomal recessive.
Dominant. His father is affected, son is also affected.
Congenital ataxia, sir, maybe.
Yeah, maybe congenital ataxic syndrome or some kind of a CA, which can sometimes early can start in early childhood. Infantile CA is also been described, but very rare.
Son has low angle jerk option.
That part may be correct, I'm not very sure. Because a child difficult to get some reflex unless you do out meticulously. We are not doing Jantasic maneuver and all. But maybe absent, we are not sure about it. His conduction was done subsequently, that was normal. Anyway, so tell me please.
Spinocerebellar ataxia.
Yes, spinocerebellar ataxia is a possibility. Only thing is the age of onset is very odd. One child has, both of them had started at the age of from since childhood, and the adult in adult his father is having even now at the age of 35 years without much worsening.
Okay.
According to the parent, they are slightly better with the years. But obviously, it has to be a family history there.
Unlikely to be Friedreich's lesson.
Because of Friedreich's autosomal recessive, moreover, he has no other features of Friedreich's. because he has got no proscamus, postocular sensory loss, and the attacks is mainly sensory in Friedreich's ataxia. So this is he came with a CA panel. That is, the routine panel was a CA 1, 2, 3, 6, 7, 10, and 12. These are the usual one they do it in the 7 common spinocerebellar attacks in this. So there was no expansion detected in this panel. So what I did was, because there is definitely there is a family history. Either it's a degenerative disease or a neurometabolic disease because of the mild improvement. So I sent the patient for a clinical exome sequencing. And this is the result. It's spinocerebellar ataxia 31. That some 8AG7, I don't know what all these things are. But it is written inherited, it's autosomal recessive, it is written. But our patient had autosomal dominant. How far this is significant, I don't know.
The first one was SCA panel.
SCA panel. That does not contain all. Here, this is a clinical exome sequencing.
Clinical exome sequencing.
But here, this is the one which has come. There is written uncertain significance. I do not know how far this is applicable in our patient. So, look at the literature, whether this can fit in with that. In fact, SCA 31 describes an old age of the age of onset is an older age group and not in an infancy like these two patients. So SCA 31 is one of the autosomal dominant neurodegenerative disorders showing lately pure cerebellar form of ataxia. It is typically a disease of late adulthood with onset peaking between 60 and 65 years of age. The mean age of disease is 58, but it can present between the ages of 8 and 83 years. Ataxia, dysarthria, horizontal gaze nystagmus are the common manifestations. The disease duration can be more than 10 years. Okay, this is only out of curiosity. I presented this case as a short case. Okay, shall I go to the next case?
But the setting does not fit both in the parent and the child, no, sir. Onset in the child is below 6 months. He had development delay, so onset we should take as infantile onset.
Correct. Father also started in early childhood. So
but this SCA 31, it is showing our mean age is 60.
Correct, exactly. So it may not be SCA 31 at all. But the problem, that is a problem in doing the genetic testing. Unless you have to corroborate with the clinical finding, don't rely on these clinical findings. Genetic testing finding. Moreover, what is written is autosomal recessive. Our patient is clearly autosomal dominant. Father is affected, son is also affected.
So if the father is not affected, can we consider ataxic CP in this child, sir? If the father is not affected.
Yeah, we can keep that possibility in mind. Definitely. Only time will prove whether it's progressing or not. That CP will improve, other things will progress.
Sir, what could be the reason for improvement in father's symptoms, sir? Over a period of time, he had some
maybe slow, but maybe very slowly progressive, relatively static course. Suppose then initially, when the degenerative disease is very slow in progression, the normal development will overtake it. So it appears as only delayed milestones. Only after some time, the degenerative pace will set in and find a gradually progression. See, some of the SMAs and all, even the degenerative, remain creatively quiescent for years together. So also some kind of muscular dystrophy like FSHD. I have seen in the age of 56, 70 years, I have seen FSHD with a totally asymptomatic. So some of them are very slowly progressing. So much so that it may not be even detected by the patient, the progression.
Okay.
So in patients with suspected ataxia, should we do the both or initially exome sequencing or the SCA panel? Which is the first way to do?
In fact, why we are doing clinical exam is it is cheaper in the sense that SCA panel costs 12,000 rupees. Okay, clinical exam will cost 13,000 rupees. With additional 10,000, you can do all the things. That is advantage. So I don't personally do SCA panel because if you do SCA panel, you detect some SCA. So what is the fun in picking up a degenerative disease for which no treatment is available? On the other hand, if you find some neurometabolic disease by clinical exome sequencing, if it is treatable, that's a good thing for the patient. So some time back, I showed one case of this methylene tetrahydrofolate reductase deficiency presenting as recurrent paraplegia. Thought initially degenerative disease. That lady improved remarkably well with treatment. So those things, some rarely you may find some neurometabolic disease treatable.
So clinical exome sequencing, what is the charge?
13,000.
13.
1-3. But if you really bargain, I have done it in many patients with 10,000.
Can we just try B12 in this case also?
Try what?
B12.
You mean the vitamin B12 and all?
Yeah.
Yeah, that we can try. I definitely can try. Okay. So I'll go to the case. It's a good case. This 26-year-old lady came with complaint that whenever she turns to the left side, for example, reversing, she first noticed when he was reversing the car and turning to the left side, she felt dizzy and oscillopsia and diplopia. So we tried turning to the left side many times, she felt these symptoms. This complaint has been there for the last 3 months. History of episodic headache with nausea for the last 4 years is precisely from migraine headache. This headache used to occur 3 to 4 per month. The complaints of dizziness and diplopia occurs more often when the patient gets a headache, even with turning with the head, without turning the head. That's what she said. No other complaint. Examination CNS is perfectly normal except for the findings in the eye examination, which I'm going to show you now. This story, in nutshell, is a person with chronic migraine. Now has come with dizziness, oscillopsia on turning the head towards the left side or turning the eyes towards the left side. That's 4 months. Sometimes it occurs along with the headache. Some days occurs even without a headache. But even it occurs without the headache, usually when the patient turns to the left side. Now, this is the eye movement examination. To the right side, then looking to the left side. There is no restriction, but you can find out the abnormality yourself, and I'll ask you later. Looking down, looking up. Asking is any place where he's seeing double intent position. Single. 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 Double. Okay. It's a vertical separation. So this is I'll show the video once again because it's very important. Asking to the right, go and look right and left. Then examine the eye movements. Right gaze, down, up, and down towards the left side. This is double. Single, double. Okay. So what are the findings in this patient? This is the only finding this patient had. Rest of the examination was normal, and this is the complaint of the patient. What do you think be the possibility? You want to see the video? I can show 1 second, no problem. You will be showing it again.
Once again.
Okay. I'll show 1 second. Yeah, good.
ഞാൻ പറഞ്ഞ പോലെ ചെയ്യണം. മോളെ ക്യാബിനോട്ട് നോക്കണ്ട, എൻ്റെ വിരലിൽ
The right, left. And right, down, up. This is the first way we
എവിടെയും രണ്ടായിട്ട് കണ്ട എനിക്ക് പറയണേ.
That's the
ഇപ്പം
right.
രണ്ടായിട്ട് കണ്ടോ? ഇപ്പോഴോ രണ്ടാണ്. ഇപ്പം
No, one.
ഒന്ന്.
Two.
ഇപ്പം രണ്ടാണ്. രണ്ടാണല്ലോ.
And it is vertical separation.
രണ്ടായിട്ട് കാണുന്നത്, മുകളിലും താഴെയായിട്ട് കാണുന്നത് സൈഡ് സൈഡ്, അപ്പ് ആൻഡ് ഡൗൺ. അങ്ങനെ നോക്കി.
That's a video. What are the findings you got? Any abnormality?
Right inferior oblique involvement, sir.
Yeah. What you said, if you're diplopia and looking up and out towards the left side, correct? So it could be left superior rectus or right inferior oblique, as you said correctly. Okay.
Vertical separation is there, so obliques mostly.
Yeah, and vertical separation can occur with recti also. No? Oblique is more torsional. Here's vertical. Both can produce, but more often with a vertical rectum, superior inferior rectus rather than with oblique. So torsion, rotation movement is, tilt is there. It is more often an oblique. Okay, what else?
Some abnormality in the horizontal saccade, sir.
Correct. What is the abnormality?
There is some pause in the middle and the eyes are going down and again coming to horizontal.
Is it that one? You find out some the smoothness of the left eye movement is not there. No, you look once again. I'll show that once again. See this. Look at the
ഞാൻ പറഞ്ഞ പോലെ ചെയ്യണം. മോളെ ക്യാബിനോട്ട് നോക്കണ്ട, എൻ്റെ വിരലിൽ.
left eye is not going so smoothly. It can broken in between some few nystagmus there. So you see that? Stops in between and goes.
താഴെ.
Is it a variant of INO?
എവിടെയും രണ്ടായിട്ട് കണ്ട എനിക്ക്
Pardon,
പറയണേ.
which?
ഇപ്പം രണ്ടായിട്ട്.
Is it some kind of a variant of internuclear ophthalmology?
Correct. It could be very good.
ഒന്ന്
But there's a vertical diplopia also looking up and down.
ഒന്ന് 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 രണ്ടായി
ഇപ്പം രണ്ടാണ്. രണ്ടാണല്ലോ. ഓക്കെ, രണ്ടായിട്ട് കാണുന്നത്, മുകളിലും താഴെയായിട്ട് കാണുന്നത് സൈഡ് സൈഡ്.
So I'll come to the finding later on. So what do you want to do now?
MRI brains.
Okay, MRI. I'll tell the findings later on the observation. So I did not pick up the abnormality initially, frankly, to tell you. On the second day when I started, I already sent the patient, saw the video once, and then only that finding caught my eye, and then called back the patient again. So this is MRI which the patient has brought. This is the T2 weighted sequence. The pons is normal, but the upper pons, there is a focal area of hyperdensity in the midline. It's a flyer sequence. Medulla, lower pons normal, middle pons normal. The uppermost part of the pons, just below the midbrain, there is some hyperdensity there. Hemispheres for all now. This is the contrast. See the contrast film. Again, the same area that is got a contrast enhancement. T1 there is nothing, but T2, this is the T1 contrast showing the enhancement in the uppermost part of the pons, the midline there. Okay, this is the zoomed up view of the post contrast. But T2, there is no hyperdensity there. Only mild hyperdensity in the prior. But the contrast enhances much more than the area of the enhancement. And this is the contrast. And this is a sagittal cut at the region of the midbrain and pons, uppermost part, you find a linear hyperdensity there like this. This abnormality was not detected in the T2 weight limit, only in the flare. T2 mild specohyperdensity, suspicious hyperdensity. So, what do you think the patient is having?
Some vascular anomaly.
Yeah, it could be most likely, less likely to be this thing, demyelinating lesion. And because that area enhancement is much more, and so what do you call, not a rounded or enhancement, something like a linear, fluffy enhancement, something like a telangiectasia or muscular malformation. That is the thing you have to keep in mind. Okay, so that is regarding the set, but the problem is not that. What is causing here? The question is the lesion responsible for the symptom of the patient? Is some vascular anomaly even maybe incidental? But first you have to find out, is it causing or not? Okay. Let us
So,
yeah, please.
head turning may cause some obstruction of the venous drainage.
Yeah, but that, my question is we are still not find out what is abnormality in the eye movement, correct? Generally, we can say whether the lesion is causing it or not. Which Dr. Butcher said, I know somebody has thought left lateral rectus weakness with them, like, yeah, then diplopia was then looking up and out.
Isn't with skew?
Very good, perfect. Which eye is affected then? Right eye, left eye?
Left eye.
Left eye.
Left eye, with skew, okay. Right.
No, is on the right side because the right eye is adducting.
Okay, so we mean to say on the right side, and then what is this jerky movements on the left side?
That could be the nystagmus.
Could be, but it's not sustained nystagmus, is it so? It's only in the middle sternums and then few jets. Then he has got diplopia looking up and out. But only looking up and out towards the left side. Okay, let us...
Up and down towards the left side means it's the left lateral, left superior or right inferior oblique.
Correct.
But the right eye is lower than the left eye.
Correct. You're right.
So how can it be? So it should be the right inferior oblique because
you're right. Is what is perfectly right. So if you look
left
at
superior rectus cannot be. Yeah.
No. Question is here. The only thing is we don't find any upward or downward movement of the position of the eye. What you observe is what diplopia looking up and to the left side.
Yes, sir.
Okay. That direction may be left superior rectus or right inferior oblique. That's all. The resting position, there is no upward movement. I mean, there is a misalignment seen. You got the point?
Yes, sir.
Yeah. So let us see. Now I'm going to show the video once again. Look very carefully any abnormality which you can pick up. Look at the horizontal. Forget about the diplopia for the time being. Okay, what you observe was that she has hypermetric saccade on the left eye. Producing nystagmoid movements in the left eye, but no persistent nystagmus, and no restriction of abduction on the left eye. So a person with abduction failure also can produce kind of hypermetric saccade and can have some nystagmus, but she has no full range of movement. And she has got vertical diplopia looking up and to the left side, means either right inferior oblique or superior, as you already thought. Now I want you to look at the root of the nose and look at the velocity of the movement of both eyes in the horizontal plane. Now look at the
lag of the right.
Exactly. Perfect. That is the answer. See, we are all concentrating on the left eye. But look now at the root of the nose and look,
Right, left,
look at the adduction lag,
right,
right eye.
full left, left. അറ്റം പോണേ അങ്ങനെ നോക്കണം കേട്ടോ. റൈറ്റ്, ലെഫ്റ്റ്, റൈറ്റ്, ലെഫ്റ്റ്, ലെഫ്റ്റ്, അപ്പ്, സ്ട്രെയിറ്റ് അപ്പ്, ഡൗൺ, അപ്പ്. ശരി.
Okay, did you find out that abnormality? All of you? Did you make
Yes,
out the adduction lag on the right side?
Yes, sir.
Yes, sir.
Yeah, that's abnormality, as Joy was telling, which was also telling it's an INO on the right eye. Now my question is, why there is hypometric saccade on the left eye? Did you also notice this hypometric saccade? Now look at the left eye.
ലെഫ്റ്റ്,
It is stopping in between,
റൈറ്റ്,
but breaking in
ഫുൾ
between,
ലെഫ്റ്റ്, ലെഫ്റ്റ്.
then goes back.
അറ്റം പോണേ അങ്ങനെ നോക്കണം കേട്ടോ. റൈറ്റ്, ലെഫ്റ്റ്,
That's also happening to the left eye, right eye, no?
But INO is the right eye,
ലെഫ്റ്റ്,
but left eye is showing the between stops in between.
സ്ട്രെയിറ്റ് അപ്പ്.
No, right abduction or right eye. Now, how to explain the hypometric saccade confined to the left eye when the patient looks to the left side? Could be due to the abducting nystagmus of the left eye. Could be, as you all thought, but not. It's not persistent. It's only one or two eject then stops. Unlike the classical INO producing abducting nystagmus goes on occurring, you keep on looking at the nystagmus should persist. But here it's only some stoppage in between and few oscillations. Finished. Now let's come back to the INO once again. What is the explanation of the abducting nystagmus? That will give the answer. Now the usual explanation, one explanation is that, now you have to listen a little carefully here. The loss of inhibitory input to the left medial rectus when the patient looks to the left side. See, when you move the eye to one direction, say for example, you move to the left side, the left lateral rectus and right medial rectus contracting. There you all know that's agonist of the movement. When any movement occurs, the antagonist should relax, should get inhibited. That means that when you look to the left side, my left medial rectus should be inhibited and right lateral should be inhibited. Okay, that is a normal physiology. So when in INO, what is happening is that, okay, right INO we are talking about here. The right eye is not adducting, understandable. But why should it produce a saccadic abnormality of the left eye? It should not, ideally. But what happens is that the right MLF carries the inhibitory input to the left medial rectus. I will explain it later on. It's just here. I will show that. In fact, I have constructed a diagram for it to make you understand. So when you look to the left side, the agonists are the left lateral rectus and the right medial rectus. That means that the antagonists have to be inhibited. That is the right lateral rectus and left medial rectus. Now, when you want to make a smooth movement on the left side, the left medial should be inhibited. Who inhibits the medial rectus? The inhibitory input left medial rectus is also carried through the MLF. So, putting in other words, MLF carries excitatory input to the ipsilateral medial rectus and inhibitory input to the contralateral medial rectus. So in our case, right MLF is affected, and there is loss of excitation of the right medial rectus, causing the adduction lag or adduction field of the right eye, and loss of inhibition of the left medial rectus. So what happens is when there is a loss of inhibition means when the left lateral rectus contract, it is prevented from doing a full abduction. Why? Because the left medial rectus is not inhibited. So the left lateral rectus cannot function fully because the left medial rectus is preventing from left lateral rectus to go to full abduction. That is why the patient is having a hypometric saccade and the patient looks to the left side. So what will be the result of loss of inhibition of the left medial rectus? When the patient looks to the left side, the left lateral rectus is prevented to carry out its full abduction due to the loss of adequate relaxation of the left medial rectus, due to the loss of inhibition of the left medial rectus, so resulting in a hypometric saccade. Now, have you understood my explanation? I will explain this thing more diagrammatically. This is a normal pathway for your lateral gaze. Left abducing nucleus through the MLF and goes to the right side. This is the excitatory burst neuron, the PPRF, and you got the saccade to the left side. Now, there is inhibitory input is also carried through the MLF here, ultimately reaches the left medial rectus neuron. That produces inhibition of the left medial rectus. When you get a lesion here in the MLF, not only the excitation of the right medial rectus is lost, the inhibition of the left medial rectus is also lost. So what will happen mean the saccade becomes slow or hypometric, because that medial rectus loss of inhibition will prevent, or that means loss of inhibition means that is also continuously acting, produce a decrease in the velocity or produce a slowing of the saccade of the left rectus. That is why the patient looks to the left side, you get hypometric saccade. Now, how to solve this issue now? There is hypometric saccade is known. Sometimes you can do duction movement, but this may not be always possible. Sometimes if it's work, it's okay, right? So even though this will not completely abate the hypometric saccade, because the persistent effort to look at the eccentric object with conjugate movement is no longer there. So the problem comes only when you conjugately move both eyes. One has to be, it should be equal. Then this problem will come.
What are we trying to solve, sir?
That the explanation is correct or wrong. The inhibition on the left medial rectus part, which I am talking about. So I just tried this thing. I did the duction movement to find out whether this hypometric saccade is disappearing or not. Because when you cover the right eye, there is no need for the right eye to look at the object. So I covered the right eye and then looked at the object. See that jerky movement, nothing disappeared. Okay. When you with both eyes open, that jerky movement is appearing. So the hypometric saccade is abated by doing duction movement. Now, next question is what is causing the vertical diplopia? So he has solved he has got IN on the right side. Then what is causing the diplopia on looking up and to the left side? That is the next problem. Okay. Is it due to muscle paralysis? Again, we did a duction in all directions to find out there is a restriction of eye movement. But each closed eye looked at the eye movement in various directions. Apparently, no restriction. In the left eye, then check the right eye to find out its inferior oblique is restricted or not. That eye movement also is down.
But you had said small weakness can be missed by
Perfect. We are perfectly right. Because this will not rule out mild weakness extraocular muscles. Perfectly right. So then what could be could it be skew deviation?
Incomitant skew.
Correct. Perfectly right. So what you did was, what will you do to find out skew deviation or not? Because there is a subtle vertical deviation in that position that you have to show whether it's due to a paralytic one or due to if it is skew deviation, it will be equal. It will be equal movement on either eye. So did a cover and
ഇപ്പോൾ 1 2 തല രണ്ടാണല്ലോ. ഞാൻ മാറ്റിയാൽ അവിടെ തന്നെ നോക്കണം കേട്ടോ. തുമ്പത്തെ നോക്കാവുള്ളേ, വേറെ എവിടെയും നോക്കരുത്, തീരുമേ. ഓക്കെ, തുമ്പത്തെ നോക്കാവുള്ളേ, തുമ്പത്തന്നെ നോക്കണം. തുമ്പത്ത് നോക്കിയില്ല. ഓക്കെ ഓക്കെ ലുക്ക്. ഓക്കെ, ടിപ്പ് ഓഫ് മൈ ഫിംഗർ, ടിപ്പ്. ഓക്കെ,
the eyes are moving up and down in that position. You have to look for, do the cover uncover test, and when the position where the patient finds diplopia. If when the eyes moves up and down, showing, and the movement is equal movement on either side. So it means it's most likely to be a skew deviation. But it can also occur with manifest latent squint as well as in skew. The manifest latent squint already heterophoria has been there earlier, but now manifesting. So so this is called an incomitant skew, as Joy was saying. What is comitant? The usual skew which you see is all comitant. That means the vertical separation is same in all directions of the keys. Looking up or down, whatever, that separation will be equal. Incomitant means only when the patient looks to one direction, one gaze, the skew will appear. Other direction skew will not be there. That is called the incomitant skew. So most cases skew deviation are comitant, meaning that the size of the hyperdeviation remains about the same in each field of the case. Comitant skew deviation arises from lesions that knocks out unilateral outward with the input corresponding to the pathways of anterior and posterior semicircular canals to equal degrees. In common skew deviation, some forms of skew deviation may be greater in one horizontal field of gaze and minimal in the opposite field of gaze. Because the hyperdeviation is greater in one lateral field of gaze than the other, this form of skew is called incomitant. It may arise from asymmetrical injury to the autolative pathways corresponding to either anterior or posterior canals as selectively injured. If it is both are affected, you get comitant skew. It's asymmetrically affected, predominantly affecting one input from either anterior or posterior, you get incomitant skew. So most likely the patient had right INO with incomitant skew. And what is the pathology? Most likely a telangiectasia. In fact, the right eye is up because the malaflation body skew right eye, but here also right eye is up.
How to differentiate from squint, manifest latent squint?
That is difficult. Difficult differentiate. But manifest latent squint in this position is very uncommon. Up and out position. Either exophoria, hypertrophy. They are upward and outward, theoretically possible, but not very common.
But we had seen one patient with left hand down, no? Previously, one patient with cataract.
Yeah, cataract. Yeah, that's correct. That is, we have seen one patient. But as told before, we cannot differentiate totally. But taking the context, he has got right INO, and along with that patient developing diplopia, that means it is most likely it is not manifest squint, but due to the associated INO. Because INO is known to produce an incomitant skew. So in fact, this patient is follow
Sir, if it is telangiectasia, then why now?
Yeah, either it may be unrelated telangiectasia which has been there. There may be some other lesion in this patient, brainstem lesion causing it, or maybe at the beginning of a demyelinating lesion, because we have to keep the patient under follow. That particular lesion did not appear to be demyelination, but I don't know, 100% one cannot be said.
Why it is not showing in T2 then?
Yeah, that's a odd point for a demyelination. Even the radiologist is also thinking in unrelated telangiectasia. In fact, patient had received IV media prednisone, many other combinations from outside with no improvement.
So your manifest squint usually develops after some prolonged use of the eyes. Usually.
Yeah, exactly. That's another point. There may be a stress factor or prolonged with the use of the eye, either the laptop or watching TV for a long period of time. That is a situation where the skin become manifest. Fatigue,
here it is present in the beginning of exam.
Yeah, beginning itself. Yeah. And moreover, the more thing, when the point is that by examination finding is objectively, there is no way to differentiate totally, but the context wise, it is more like a skew deviation. So Joy's point was correct. You can't differentiate totally, but very unlikely why should it come together simultaneously? So that makes you think more like a due to the INO itself.
So one unrelated question: how does the manifestation squint improve with exercise? Because exercise is putting the muscle into action that would tire the muscle. No.
No, we are in fact exercise means convergence exercise. We are making the what is normally when the patients put a heterophoria or latent squint, we make the latent squint make it disappear or make it orthotropic or in parallel because of our normal vergent system. When we have got a vergent system or full vergent system, which is for your fusional vergent system, then you are able to mild misalignment can be made into correct by the vergent system. So what happens in prolonged use of the eyes and stressful situation is that your vergent system breaks down. So the fusional vergent system breaks down, the eye goes into its original lazy position. So in the exercise, what we are trying to do is your exercise to improve your vergence. So ask the patient look towards near object and upper, that way the vergence is made more powerful. That is exercise we do, not the exercise of the lateral and upward movement. In fact, the ocular muscles are normal. They're normal range of movement, individually if you do the reduction movement. When it comes binocularly, the problem comes. And the malalignment has to be corrected by your vergence. So you make the vergence more perfect. The other method is to put a prism glass so that the alignment is made tilted, tilted into the required position. Okay.
This is a tough case.
It's a tough case. In fact, I initially did not pick up the adduction lag. I only picked up the saccadic, hypometric saccade and the future. Then I was thinking, and diplopia, I was thinking what is causing it and all. Then I thought initially, frankly, I thought it's a concomitant squint is manifest. But why should occur recently? There is a thing again. So I checked the video once again. Then only found out the abnormality.
Can hypometric saccadia happen just in one eye?
No, that's another point. You're perfectly right. If you got a cerebral lesion, what is hypometric should be bilateral, right? But it can occur one eye if it is due to muscle paralysis. Like for example, if it's a concomitant squint, that eye is straining, that can what is hypometric saccade. That is my argument initially, or way of thinking initially. That can produce unilaterally. The usual hypometric saccade which you see in brainstem cerebral should be bilateral. But hypometric saccade due to one muscle affection, extraocular muscle affection, that can produce unilateral affection.
Okay, sir.
There is, for example, lateral rectus weakness, medial rectus, that can produce hypometric saccade. It's actually not called hypometric saccade. In fact, it should be restriction of that eye-bound movement. It appears like a saccadic.
So then, will exercise help? Muscle exercise.
In case when the INO recovers, everything will recover. The inhibitory input improves, saccadic glass flowing, everything will improve. In fact, it is a jerky movements which causes the oscillopsia in this patient. Okay, now I show you two things. This is positional vertigo patient. I'm going to tell you one finding, which is a very simple bedside finding, by which you can diagnose the side of lesion. That's why I thought I will bring these two cases here. Because this side of lesion is very important because the maneuver which you advise or do depends upon the side of lesion or the side of affection. Unless you know the side of affection, you cannot design your maneuver. So this 45-year-old man has committed positional vertigo of 3 days duration. Look at this patient. This patient is lying flat on the bed.
കറക്റ്റ് എനിക്കറിയാം.
It is beating to the left side. It stops. Forget about the initial part.
മാറിയല്ലേ?
Now I am turning to the left side.
ഇനി വലത്തോട്ട്.
Turning the right side. It beats towards the right side. That means it's a geotropic determination. Then stops after some time. Sorry, I think the video is little bit some problem with the video. Just 1 minute, I think.
അങ്ങനെ നേരെ straight back.
Richard is correct, you're right. I'll show the video once again. When he edited too much. Now I'm going to the right side. Sorry, left side. It beats towards the left. Now I'm straight back.
മാറിയല്ലേ? ഇനി നേരെയാക്കി.
Lying straight, sorry.
ഇനി വലത്തോട്ട്.
Then trying to the right side. Look to the right side, beating to the right side. It was high amplitude or more to go towards the right side.
വലത്തോട്ട് കൊണ്ടുപോയി. നേരെ നോക്കിക്കാതെ.
And stopped. No, I showed one side because the initial part I did not. This is the straight ahead. Now turning to left side, it beating towards the left side.
കറക്റ്റ് എനിക്കറിയാം.
Then it stops.
മാറിയല്ലേ?
Then
ഇനി നേരെയാക്കി.
then made it straight ahead. No nystagmus.
ഇനി വലത്തോട്ട്.
Then turning to the right side. And Mr. beats to the right side. Okay, obviously geotropic nystagmus, correct? The question now is which canal is affected, right side or left side?
Right side.
Right side, because
So nystagmus amplitude is higher on the right side.
and the right, perfectly right. But sometimes, it's difficult to find out which side is more. We are difficult to find out whether the amplitude is more on one side or the other. A pattern may look same someday. This is very clear. Now, in that case, what you do is this particular test. See, what is called lying down test. So the patient is sitting up. I am going to make it lie down straight back.
അങ്ങനെ നേരെ straight back.
Straight. Just, I'm not turning in any direction. Just lying flat. You see the nystagmus face to the left side. I don't turn the head to any direction. Just lying flat on the bed. Okay. If you first find out geotropic or apogeotropic, even if you does not find out which side is more amplitude, do the lying down test. In the case of geotropic nystagmus, you find the direction of the nystagmus is opposite to the affected ear with the lying down test. Okay. If you do that side lying supine roll test, the amplitude will be more on the side of the affected ear. When lying down test, it will be to the opposite side. See, here you find the right side is more affected, canal is more affected. So, but lying down, the nystagmus beating to the left side. I will explain it later on. So, lying down to the sitting position, the nystagmus beats to the left side, shows the canal affected is the right side. Okay. Now, what is the explanation is that this very, if you remember this, remember this diagram is very easy to understand. So this is the position of your canal, horizontal canal, anterior canal, and the posterior canal. So when the head is pitched by forward by 30 degrees, the canal is horizontal. with no incline, and there is no nystagmus because the particle is not moving either way. Imagine this patient has got a particle here on the left side here. Now, as the lat canal is oriented with ambulary and elevated 30 degrees above the horizontal, when the head is in the upright position, there can be slow movement to the outer cornea away from the cupola. So when you make your head straight ahead, rather than, see, this is in this position, the canal is horizontal. When you make it straight ahead, the canal is inclined downward a little bit. The anti-umbrella become up. This has become low, posterior part become low. Since the autocornea gravitates away from the cupola, the canal is inhibited. Because as well as the horizontal canal is concerned, when the endolymph flow is towards the ampulla, it stimulates it. It is away from the ampulla, it inhibits it, the basic concept. So what will happen? You get a pseudo-spontaneous nystagmus speeds towards the healthy ear. Because that canal is inhibited means the nystagmus is to the contralateral side. If it is stimulated, nystagmus is to the same side. Okay. Now what is happening when you lie down? What is happening? This flow is up. So and same thing, that autocorneal movement is exaggerated, going backward, away from it. So you get nystagmus to the contralateral side. That's the principle of in the case of neotropic nystagmus. The canal lithiasis, the particle move away from the ampulla, that canal gets stimulated in the lying down position. Now, what happens if you bend? This is the one when you're lying down, the autocornea gravitate away from the ampulla. Ampulla is anterior. So in geotropic type, or lying down, the nystagmus speeds to the unaffected side. Now, what happens if you bend the head forward, so-called bowing position, when the head is bowed forward by 90 degrees like this. Now, instead of lying down, this bend bow forward. Now the ampulla is dependent. So the autocornea gravitates towards the ampulla, stimulating it, causing nystagmus speeding towards the affected ear. So the ampulla flow is towards it, that means stimulated to the affected ear. So in bowing, the nystagmus is to the same affected side. When lying down, the nystagmus is away from the affected ear. That is the principle of your bow and lean test. Now I'll show another patient of positional vertigo. Let us this patient. He also has got positional vertigo. Turning the head to the right side. Nystagmus speeds
away from the ground.
Towards the left side.
Towards the left, away from the ground.
Turn the head to the right side. Nystagmus speeding. Now, straight ahead again. Turn the head to the left side. Turn to the left side, the meet towards the right side.
It's again meeting towards the right side, away from the ground.
On turning left side, the nystagmus is more higher amplitude. So what type of PPPV, horizontal PPPV?
Right pupillar lithiasis.
Correct, perfect. It's an apogeotropic nystagmus one, and it is the right side. Even the nystagmus is more towards turning the head to the left side. That means the opposite side of the maximum amplitude. Here again, the point is that sometimes you may not be able to find out by just looking at the amplitude which is said more affected or not. Okay. Now do the lying down test. Again, the patient is sitting and the patient lying down.
Lying down, lying down, lying down.
In lying down, it beats towards the right side. So this is one side. So when you do the lying down test in geotropic type, the nystagmus beats to the unaffected side, normal side. On the other hand, in apogeotropic type, when you lie down, the nystagmus beats towards the affected side. Okay, so by just looking at this, you can differentiate whether which side is affected. one simple thing, when you make the patient sit on your cot and lie down itself, that itself you can find out the nystagmus lying beating to one side. That will give a clue that it is a which side is affected. Then you look for the geotropic, apogeotropic, then you find out which side is affected. So apogeotropic BPPV, you're lying down from sitting, lying not lying down, or lying to sitting position, sitting to lying position, or lying from sitting position, the nystagmus speaks to the right, showing that canal is affected from the right side, just opposite of what you can in geotropic type. It's unaffected side. This is again the pictorial representation, how this is occurring. This is orbital canal, this is the norm sitting position. This is the position of the canal lithiasis. The usual one is the posterior canal lithiasis. Here is the otoconia. So when you tilt the head backward, the patient is not sitting backward like this, supine position. The nose is up. Then what happened? This canal will come this side, your ampulla goes up. So the particle move away from the ampulla. When the particles move away from the ampulla, you get that canal get inhibited. That means the nystagmus move away from the affected ear to the opposite side. So if it's right, this is left side is affected, the nystagmus moves to the right side, just like our patient. This is the canal lithiasis type. Now, in the case of cupular lithiasis, the patient is sitting. This is the cupular lithiasis attached to the cupula. When you lie backward, again the canal goes upward. But what happens is, because of the weighted, the movement of the flow is towards the ampulla. Because this is the weighted cupula, that shift in this direction. So the flow is towards the ampulla. So you get that canal gets stimulated, nystagmus towards the affected side. Not towards from, it's so towards the affected side.
So this geotropic and apogeotropic is only for horizontal semicircular canal.
Yeah, only in fact that can also occur with the posterior canal, but usually this is what we talked is in the horizontal canal BPP. In the case of in the posterior canal BPP also there is a geotropic, apogeotropic type, but the usual one what we come across posterior canal, whether it is canal lithiasis or cupular lithiasis, it is a geotropic type. There's a rare posterior canal BPPV due to the otoconia in the crus communis, that is away from the, when the two canals join together, and that area, if the particle remain, you get the opposite. That is the geotropic type. So apogeotropic type. So usual type of posterior canal BPPV is geotropic. That is when you turn the head to the right, when you keep the head to hanging down the right side. The fast component, the vertical nystagmus, and the rotary component is towards that ground. It's towards the right side. Then if it is keep the head right side, nystagmus beats in the anti-clockwise direction towards the ground. That's the geotropic type. In posterior canal BPP, whether it is cupular lithiasis, whether it is canal lithiasis, when you tilt the head, this is upward, that the ampulla become up and the particles will move away from the ampulla. If it is weighted also, it tilts away from the ampulla. So in the posterior canal, the flow is away from the ampulla, that canal gets stimulated. In fact, some time back, I had taken a class on BPPV. In that I have shown how the cupula becomes higher up in the case of posterior canal. This lying down nystagmus is only for the horizontal canal. Because it's important once you know the which canal is affected, with two settings of Gufoni's maneuver, this vertigo will subside. In fact, even by telephonic by telephone itself, you can correct the patient's illness. Send the video of the nystagmus. You can ask them to say you type apogeotropic, type Gufoni maneuver. You can do look at the YouTube and get the answer. They can do it by themselves. I treated to few patients like that. So any questions? Yes. Okay. Shall I go to next case?
Yes, sir.
Okay. Now, it's a short case, in fact, not very interesting anyway. The story of a 72-year-old diabetic lady is to have radiating paresthesia of the left lower limb for the last 6 months. It's a similar complaint of the right lower limb 2 months later. It's more on standing and walking and decrease on sitting. It's a pain along both lower limbs, increased on sneezing and coughing, and difficulty in walking for the last 2 months. Okay. Now this is the examination finding. Tone was normal. He had weakness of both hip flexors. He was weak bilaterally. Knee extension was also weak. Dorsiflexion was also weak, but hip flexion needs us more weak than the dorsiflexion. Very poor patients, very poorly cooperating. EHL was weak, and the flexion was good. Abduction was also weak. Upper limb reflex is normal. Right knee jack is elicitable. Left is brisk. Ankle jack is also elicitable.
Please.
Plantar was flexor. This sensation impaired over both feet. Distal part of both feet. But taking pain, left lower limb is all. It's all equal throughout. The right lower limb, there is a somewhere around the it says you can feel only at that level. Flip moment. It's impaired vibration JPS or both. Cellular was negative. Abdominal reflex was intact, just sensitive. Okay, this is a patient. Now the gait is the gait of the patient. Thrombus was positive. She walks with a broad-based gait. She cannot stand on heel. Partially, not fully. The toe walking was slightly better than the heel walk. But she could not get up on the sitting without support. Some suggestion of a badly, Dundelberg positivity is there. Okay, this is the story. So findings confined to both lower limbs, motor, wasting of both cortices, weakness of both hip flexors, knee extensions about grade 3. Weakness dorsiflexus of angle, EHL bilaterally about gait 4. Cannot get up from chair without support. Tunnelberg test is positive bilaterally. TTR, right knee jack is normal, left brisker compared to the right side. Angle jack 1+ bilaterally. Abdominal reflex absent bilaterally. Plantar's indefinite. Sensation, touch decreased distal part of the both feet. Pain decrease in the right leg up to the mid-shin. Impaired posture collar sensation on both toes. Romberg's positive, gait broad-based cordless gait. So what do you think the patient is having? Any clarifications you can ask again. I'll show the video once again. Anyone? What do you think?
Element disease, sir.
Okay.
Except knee jerk brisk on other side.
On the left side, correct. It's a little tricky case in the sense that this is how the patient presents.
Okay. She has a myelopathy and a diabetic neuropathy.
Okay.
Diabetic neuropathy is distal symmetrical plus diabetic amyotrophy. And she has got a Lermitis symptom.
Lermit symptoms ഉണ്ടായിരുന്നില്ല.
So you said increased on sneezing.
Pain the left, both the lower limbs was that complaint, not in the.
No, upper limb, lower limb.
Lower limb, pain of increased on sneezing. Pain the lower limb only.
Abdominal absent plus brisk left.
Abdomen is decreased, correct. Abdomen is. Yeah, it is
left
pretty.
Left knee jack is brisk.
Correct, exactly. This is the problem, really had problem. Because, but at the same time, there is suggestion of element weakness in the lower limb. The throat was not spastic, there is mild wasting of the thigh. And thigh muscles were more weak than the distal muscles.
And the quadriceps wasted.
Yeah, correct. So, what all will you take? What do you think? What are the possibilities you have to keep in mind?
First is diabetic, sir. Diabetic amyotrophy.
Okay.
Second is
there is radicular neuropathy involving diabetic.
Yeah, but your complaint was radiating pain around both the lower limb and standing, and sneezing. The pain increases along the lower limb.
That can happen in radiculopathy also, no, sir. Diabetic.
But then that radiculopathy, diabetic agreed, but not by. Diabetic neuropathy or amyotrophy, the pain will not increase by coughing and sneezing.
Compressive.
Disc collapse, agreed. So is it peripheral neuropathy with diabetic amyotrophy, or is it a myelopathy associated there in this patient because the asymmetric knee jack is slightly brisk on the left side, and he has got also decreased pain on the right lower limb, again pointing to some kind of a myelopathy on the left side. Is it likely that possibility? Amyotrophy expect knee jack to be absent, no? Or at least decreased.
Could be a combination of all the three.
Could be, yeah, correct. So in fact, frankly speaking, I myself I was a little confused in this patient. Now, partly because the patient is not that very cooperative also. But the findings, I was also thinking whether it could be myelopathy in that patient. But let us see the investigations. This is the MRI of the patient.
Is sensory impairment up to the shin usually take it for a mononeuritis multiplex or a radiculopathy?
Because the problem, see, the knee jack is brisk on the left side, and the parathalamic sensation is lost on the right side. It could be a part of goes with the myelopathy. Okay. But it could well be a radiculopathy pain also. That's also possible. One cannot be certain about that. But if it is a myelopathy is dominant, why the proximal muscles are more weak than the distal muscles? The thigh cannot flex the thigh, can extend the knee. That means it's more like a element rather than human. So the proximal muscle weakness is LMN. Then the distal muscle weakness could be LMN or UMN, we don't know. Right?
Proximal can be UMN in ischemic myelopathy, no?
Yeah, that's true. That's true. That's true.
But wasting.
Yeah. That's wasting is against. So many points are odd. So nothing is gelling in. So let's say the investigation. He has got a disc collapse at L5. Sorry, L4, L5. L4, L5 and S5. I could show the axial cut. The thoracic spinal cord is normal. There is no cord lesion. And this is the axial cut. There is a significant narrowing in that area. In L4, L5, there's significant narrowing of the canal. That will explain the patient's radicular pain, the pain while standing and all can be explained. So this was the L5S1 root distribution, but minimal weakness. But that will not explain the proximal weakness. So look at the pyramidal, we look at the myelopathy part, cervical cord is normal, and the thoracic cord is also normal. In fact, I did a axial thoracic also, that is also normal.
Cervical?
Cervical is also normal. Stain, we know the first thing, I think I did not show that thing. But I'll show that thing, I think. In fact, that picture is, there is a whole picture, whole spine showing that thing, and even that I deleted that picture. That is normal. And there is nothing in the upper limb also. Upper limbs are entirely normal, no symptoms pertaining to the upper limb. So what else you need?
Nerve conduction.
Nerve conduction, okay. Let us see the nerve conduction. This is the ESR 53. ANA was done and CICP normal. This is a nerve conduction. Perineal amplitude is low. The sensory potentials are all normal. But remember, they are done in superficial perineal surveillance surveillance. And FA latency is normal. So, what will you do now in this patient?
So, femoral conduction?
Femoral conduction, the saphenous potential is normal.
Motor was not done.
Motor, in fact, this case is not mine. So I asked for it, but I don't know whether it's done or not. I don't think it must have been done.
EMG is a needle?
That I did not do. Because EMG, anyway, we know it's going to be, to differentiate whether the thigh muscle is LMN and UMN. But already there's a wasting there. And the weakness is not like a pyramidal weakness. And we are not found any myelopathic imaging evidence of myelopathy. So obviously it is a low motor neuron.
Not to exclude MND, sir, because LMN plus UMN lesion in the left thigh.
Oh, okay, you have got a point there. But you have got a sensory involvement. Parathalamic sensory involvement at the right lobe. We think it's a myelopathy. Okay, so CSF, you want CSF or not? Because we don't know what is the cause. The CSF was done. CSF is showing is normal. CSF 8. And there is one other reason why the CSF was done by Dr. Divi, because the patient had some past history of some tuberculosis or something, that is the abdominal tuberculosis, some gland, something was there. CSF is also normal. Now, what do you want to do now? In fact, if you put the patient IVMB for 5 days, because I thought this patient's got a diabetic amyotrophy. Because that muscle was LMN, and I don't know how to explain the bliss check in that patient. It's just not fitting with the myelopathy. I considered myelopathy in the expert examination, but investigation did not prove anything. So I thought, why don't you give that prednisone? This is after 5 years of that prednisone. Yes, hip muscle has become good power. Knee exercises weak, we get good power in the knee exercise.
ഇതും തള്ളിക്കമ്മ എൻ്റെ കയ്യിലോട്ട് തള്ളു മുമ്പോട്ട് അത് തള്ളു 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 ഓക്കെ ഇതും പിടിച്ചോ
Flexion was slightly better. Also,
ചവിട്ടിക്കമ്മ ചവിട്ട് ആഞ്ഞ് ചവിട്ട് കാലകത്തി പിടിച്ച് അടുപ്പിക്കണ്ടേ
adduction is also normal.
ആ മതി നിൽക്കേ പൊക്ക് പൊക്ക് ആ മതി
I check the hip flexion once again.
പൊക്ക് പൊക്ക് അത് സാരമില്ല
The reflexes and other findings remain the same. Right knee jerk is 1 plus, left knee jerk is slightly plus. Angle jerk was also it. I check the sensation, check the bladder again.
ഒരേപോലെയാണോ വ്യത്യാസം ഉണ്ടോ എന്ന് പറയണം
This time also she was complaining that the sleep there.
പാതിൽ കുറവാ കൂടുമ്പോ പറയണേ കൂടുന്നോ ഓക്കെ
Very.
ഇനി കൂടുമ്പോ പറയണം ശരി ഇപ്പൊ ഇല്ല
So that's the story.
So was it given for 5 days?
5 days.
1 gram or 500 milligram?
500 milligram. 500 milligram. She's a diabetic lady. So even the first examination, how far she's when exaggerating, I don't know, but definitely definite difference is there without treatment. Okay. If you ask me whether I'm 100% sure about the amyotrophy, I'm not very sure. But this is the only reasonable thing which you can find out based on the findings in this patient. Because there is no radiological evidence of any myelopathy.
But the hard findings are more in favor of element.
Yeah, correct. Okay, shall we close?
Yes, sir.
Yeah,
Good night.
okay. Good night, good night.
Good night, good night.
Good night.
The second, I think the second case is a really good case, no? Second case.
വയസ്സുകാലത്ത് തലേ കയറുന്നില്ല സാറേ തലയിലൊക്കെ കയറുന്നില്ല
That is a good case. And the vertigo part, I mean, the BPP is also, even that particular findings we do, it is a very useful bedside test. Because many times you may not find the increase in amplitude on one side, you will not get it. So that way, this finding will be going to help you.
So one question, sir.
Yeah, please.
So when is a speech in IAN, sir? IAN call.
My talk.
Yes, sir.
I think it's on Friday. That's
what is the talk about, sir?
The talk is tricks of the trade in neurological examination. I'm only showing certain bits, certain what you call small points by which you can diagnose clinically. Small tips in the examination, which can give a clue to the diagnosis. Even if you're not coming, I can show it on this forum here, no problem.
Yes, sir. Thank you.
Yes, sir. Please, sir.
Yeah, it's
Yes.
only 15 minutes talk, so I can easily finish any one of these sessions.
Most accepted.
Okay, right, I will do that. But some of them we almost have seen in my talk, I mean in my this fine program, but anyway, you can show it all.
സാറിന്റെ സ്റ്റുഡൻസ് ഒക്കെ കുറെ കണ്ടിട്ടുണ്ടാവും എന്നാലും
Yeah, okay.
കുറെ ഞുണക്ക് പോയിന്റ്സ് ഒക്കെ ഞങ്ങളെ കൊണ്ട് കണ്ടിട്ടുണ്ട് ശരി ഗുഡ് നൈറ്റ് സർ
Good night, good night. Good night.
Sir.
Right, sir.
Nice, sir.
Good night. Thank you for listening.